small cell lung cancer. Lung cancer, 1 decade ago, the survival is very, very poor. But remember earlier, we showed that data, lung cancer survival, the mortality will go down very fast. And this one, in particular in Asia, is an interesting one. There's a particular mutation on a molecule called EGFR receptor, which I'm very active working on this molecule. There's a particular mutation which is called activation mutation. And this particular mutation in Caucasian lung cancer only about 8%, but in Asia, Hong Kong, China, Taiwan, Korea, Japan, all the same, 40 to 50%. And once you have that mutation, it's not good, okay? That's the cause of cancer, the cause of lung cancer. But it was so lucky that the scientists developed the kinase inhibitor, the first generation kinase inhibitor called Tarceva or Alotinib, whatever you want to call. This one is an inhibitor for this one. So once the lung cancer patient has this mutation, you treat this drug, you inhibit it. If you're a lung cancer patient, you don't have this mutation, you don't know how to deal with it. But with this mutation, 2 to 3 year survival rate. But then after that, resistance came back. Cancer cell is very smart. You develop drug? Fine. You kill me? Fine. But I mutated. So it becomes resistant, then recurrent. So but this one is not too bad because this drug is 2 to 3 years. And therefore, in 2004, the drug was approved by FDA. But because those patients who recurrent, actually, just last year, and by the way, there are a lot of them are non-smoking women. Women. Last year to this year, I have 3 friends, all female, 2 are in Houston, 1 in Taiwan. All die with this disease. All of them has this mutation. All of them survive for 2 to 3 years. And at the time when they survived that 2 to 3 years, I still remember one of them who was, they are my friend, okay? And she was treated in MD Anderson. And she came to my office. She complained. She said, Min Chi, how come Dr. So-and-so, okay, all these doctors I recommended to see the doctor. Diagnosis say it's incurable disease. I'm okay. She took this drug. She said, I feel good. I can eat, I can do anything. Why she said, my diagnosis, she said incurable disease. Why she say I'm incurable? You're incurable. Because she know, because based on data, we know 2 years later or 3 years later, you're going to recurrent. And when recurrent, you're dying. She passed away already. And we actually work on the next generation of drug. I was hoping that even before we publish it, we can identify that drug, and then, but it was too late. Anyway, so this first generation of TKI, then after that, everybody is developed second generation. Once you recurrent, what happens? So in the lab, we start to try to, in clinical side and lab side, join together to understand why they develop resistance. And then you know there's another mutation, a very famous mutation called T30790 methionine mutation. Of course, there are some other mechanism. And then people start to develop second generation of this drug. And this second generation drug is very interesting. This one, in the animal study, work on those resistant tumor. But when you go to clinical trial, it doesn't work. And one had to be used in combination with some other drug. But anyway, it's still being approved by FDA, but still targeted for the first original population of patients because those resistant patients still doesn't work. And just this year, 2015, there are 2 papers come out in New England Journal of Medicine, and there are 2 drugs. It's third generation of drug targeting this one. And amazing, those resistant patients from this drug work. This drug has not been FDA approved yet. It will be approved soon because that clinical trial data very, very impressive. But unfortunately, they also identify less than 1 year resistance came out and then identify another mutation. So what does that mean? Does that mean sometimes we joke in the lab, so does this You identify mutation, you develop first-generation drug, then you develop recurrent, then you develop second-generation drug, and then you continue. What's that for? Keep me a job? So I can have something to continue to work on it? That's not what we're supposed to do. Can we think about something? Just stop it. And today is not scientific talk, but I just want to share with you, those strategies are coming. This type of cancer, soon, you don't have the fourth generation drug. You don't need it. It's probably a certain type of combination, and either they cure or they cannot cure. Okay, it's coming. So that's, when I say it's coming, we're also involved too. And we don't know yet, but there's a lot of hope from the animal study. So that's what we need. You need a one time and cure. What you don't want is, you have one drug, and you live another 1 year, then you recurrent, then you die, then later on you develop another drug, then another patient, then live for another year, then die again. What we need is something, just cure. We need a magic bullet, and it's coming. In addition to the one I just mentioned about combination therapy, there's another new type of therapy. And many people, today when I talk to the scientists here, that everybody's known this so-called new immunocheckpoint therapy. So we don't have to use a jargon of the scientific jargon, immunocheckpoint, that's not important. A simple term is, make your cell very healthy, enhance your immune response, you wouldn't have no cancer. Because all the